So yeah, so just to introduce things really, child development, there's a whole range of we call milestones. So things that we would expect a child to be doing at a certain age. And there are kind of key moments when you expect those milestones to happen. But there's a whole range. This is the important thing to understand. Sometimes some children are different than others. Some children develop more rapidly than others. And so there are a whole range of what we would call kind of normal development. But it's important to understand what is a bit different from normal, so that when we find children who are at risk of delays, we can help the families. And in this setting, that can mean anything from helping them with things like physical therapy, helping them maybe with baby walkers. Also, a lot of education is very important, because you'll find, and you know this better than I do, people, if they think there is some problem with the child, they might believe it's devil business, and then they're going to all different places and doing all these kind of country medicine things. So it's really important that we try to do education with families so they don't go in that way. So really there's 4 areas of child development, and we're going to go through all of them, and then some of the more common problems that can happen. And I wanted to start with the gross motor development. So the first thing to talk about really is head control. So some of this I know quite instinctively, because we've just had Finley, just had him as a baby. The first 2 months was a bit strange, because he was still supposed to be in utero, so he was doing things that are completely off the charts. And now he is, in some ways, he's more like a newborn. In other ways, he is more developed than that. But there are certain things that even a newborn will be able to do. So, for example, most newborns will be able to do what you can see in that picture. There'll be an ability to extend the head in a ventral position. So that means if you're holding the baby as the man is there, you'll see that often the head will be looking up, and that's because the extensor muscles are often quite well developed relative to the flexor muscles. As they start to develop more, they'll start to lift their head up prone, and they'll be moving from side to side. And then once they get to about 3 months, they'll be able to hold their head upright while they're sitting. So they may not be able to sit up by themselves. In fact, at 3 months they won't, but they'll be able to at least hold their head in an upright position. And that's about what Finley can do now. So that's the brief beginning. Now, something that's really important to understand, I know some of you are aware of primitive reflexes already, because I've seen you do them. I've seen you test them in babies. And that's a really good thing to do, because if you're starting to see asymmetrical reflexes or absent reflexes, that does tell you there may be some serious problem coming on. So the obvious one that everybody knows is the grasp reflex. That's very, very simple. You just put a finger inside next to a baby's fingers, and they will hold on to it. Then you've also got the Morrow reflex. Can anyone describe to me a Morrow reflex? Like what's involved in a Morrow reflex? It's okay. Someone can just say something. Have a guess.
Yeah. So a Morrow reflex is like trying to lifting the child with the hands, both hands, and then having your hand at the back of the head or neck to support, and then try to release the hand that you lift the child up, and then the child goes back with the head in your hand that is there to support. The child extends and flex.
Very good. Perfect. That's a very good description. So you're holding the head up, then you're releasing it suddenly, so the neck is extended, and then you'll see what will happen is all 4 limbs should extend and then flex very quickly. Now that's quite an important reflex, because if you see that it's asymmetrical, so if you see one side is extending and flexing and there's no movement on the other side, that could tell you there's a problem, possibly cerebral palsy or something else. We're going to talk about that a bit later as well. A rooting reflex, everybody knows this as well. If you've had a baby, with Finley, this was quite scary, because As soon as you touch, when they're very little, if you touch their cheek, the baby will turn towards it and will almost start to try to feed. That's really the purpose of that, is so that the baby's able to feed well. Stepping reflex, I'll show you a picture of that in a minute, as well as the asymmetrical neck reflex. But the important thing is these reflexes, by the time a child reaches at least 6 months, and sometimes even by 4 months, they should have disappeared. You won't get them anymore, and they're replaced by different developmental stages. But if you have a child who was maybe born prematurely, or has been unwell, or there was some issues during labor, doing these primitive reflexes is really important, because it'll tell you what's really happening with the child. That's much more helpful than doing necessarily even doing a scan or anything like that. That'll tell you, are we going to have some development delays, or is everything going to be okay? So as you said, this is the Moro reflex, and you can see the picture there. All the limbs, well, certainly the upper limbs, are being extended, and the head has suddenly dropped backwards there. And then this is what's called the asymmetrical neck reflex. So if you turn the child's head towards one side, one of their, so the child's head is turned toward their left, you'll find that the arm starts to go that way as well. And you'll have, like, it's called a fencing posture. So the arm's sticking out and the other arm is kind of held up in like a little fist. It's quite a strange reflex to see, but it does exist, and you want to check that on both sides. And this is, that's what it says on the tin. Stepping reflex, basically you hold up a child age 0 to 2 or 3 months, and you'll find that they will actually start almost trying to walk. It's not that they can walk, but it's a reflex that is part of their development. So the important thing is those should be disappearing by the time a child starts to get older. If they're still present, then you've got a bit of a problem. But as you get a bit older, the child, by 6 to 8 months, you should have an infant who can sit without support. So they shouldn't need to be held up. Now, right now, Finley, if I try to put Finley to sit up and I leave him by himself, he will just fall to one side because he's only 5 months, and really he's only like 11 weeks because he was born so early. So in order for a child to sit up, they need two things in place, two reflexes that come later. One of them we call a propping reflex, which means that as they fall, their body starts to come back to normal. And similarly, a righting reflex, which basically means that the body has sufficient core strength, so they don't just kind of fall over to one side when they're sitting. So those are quite important things to know. The main thing we get concerned about is if we see a child who is past 9 months, or 10, 11 months, and they can't sit independently, that again would tell you that there may be some delay in development, possibly a neurological condition or a muscular weakness or something like that. So if you ever get a history of a child who's had something happen at birth, this is a really important thing to ask yourself: is the child sitting? And you'll see, we actually have a lot of children who coming in and out of under 5 clinic who actually they're sometimes even 13, 14 months and they can't sit up, and it's because of things that happened at birth. So there's one little baby who was born and had basically recurrent convulsions, and where it was admitted for about 3 weeks, and that baby still is not able to sit up. So yeah, good. So going to have a little movie in a second, but once they're sitting, the next mobility is usually crawling. But be aware, some babies don't actually crawl. They do something called bottom shuffling, where they're sitting on their bottoms and they're kind of pushing themselves along with their hands. And that may mean that they actually walk a little bit later. But the important thing is 10 months, you've normally got a baby who can cruise around the furniture by themselves. So by cruising, I mean they are holding on to chairs and tables and they're moving around. And usually by 12 months, they're walking independently. But be aware that that's very broad. So I'm aware, like myself, I didn't start walking until 14 months. So I was very late, but some children may be walking even at 9 or 10 months. Huge variation. But the cutoff really is 18 months. If you have an 18-month child who is not walking, you need to try to find out why, because that is not normal. So before we go on to fine motor development, there's a tiny little movie I want to show you guys. I'm going to see if I can get this to work. Let me see if this will go. And it's just a very brief kind of movie overview of some of these developments. So can everyone see Illustrated Textbook of Pediatrics?
Yeah.
Yeah, good. Let me just make sure the sound is going to share as well. Share sound. Sometimes this can be a problem. Let's try. Let's see if this works. So yeah, there's just a little picture of basically what, kind of what I've been saying there, really, just to see, really how things are. I always find movies kind of easier to understand than just someone talking. So the important thing to realize is the two kind of key points, really. If a child's not sitting at 9 months or not walking by 18 months, then you need to look into why. That's quite important, really. And if that doesn't happen, and if a lot of the time these things can be missed, but the sooner we know there's a problem, the easier it is to try to do something about it and try to help the family. So second big area goes a little bit along with gross motor, but fine motor development. And just be aware that if you're doing a formal development assessment, and sometimes this may come up in an OSCE as well. Certainly my pediatric OSCE, when I was going through my PEDS training, we had to do this, and we had to be quite structured in the way we did a development assessment. So fine motor development, be aware that visual and fine motor skills are very much assessed together, because often you'll have children reaching for things, drawing things, all those things, really. So first thing you'll find, a newborn, they'll basically just be staring at faces or lights. Again, from experience, when we had Finley in the neonatal intensive care unit, that was kind of all he did, just staring at the light. By the time they get to 6 weeks, they will start to follow objects much more. So if they see something interesting or a face that they recognize, they'll stare at the face and they'll be following it all the way around the room. And later on, and Finley's starting this now, they start looking at their hands and they start to play with their hands. So right now, Finley's got both of his hands and he will just kind of hold them together and play with them and look at his fingers, and they start to discover their hands. So those are really the three things that happen. And then as children get a bit older, the primitive reflexes we talk about disappear, and you get much more solid longer term things. So rather than having the grasp reflex, you have a palmar grasp. So rather than just holding their fingers around something, they will hold everything together with their whole palm. So if you put a rattle or a finger or something into baby's palm, they will grasp the whole hand. Usually by 10 months, they'll get a pincer grip. So they'll be able to hold their thumb and finger, and they'll start to pick things up using just 2 fingers, like they might try to pick up a pen or maybe even food or rice. And then 12 months, they start pointing. And that's quite an important thing, because that shows that they recognize that objects are different from each other. So that is usually at about 12 months. And then we have what we call our preschool motor skills, 18 months, scribbling with a pencil, and then towers, and then they start being able to copy things. And gradually over time, they start to be able to copy and draw more complex shapes. So the first thing children can draw is usually a circle. No one can draw a perfect circle, but they can at least go in a circle. Then they can put two lines in a cross, and then squares and triangles generally come later. So if you're doing a development assessment on a 2 or 3 year old, you may just give them a pen and a paper and ask them to draw things and see how they go. And that can tell you quite a lot. And where I work here in the UK, we have these posters up everywhere, just showing us where the various different milestones are, because it's actually quite hard to remember what every baby should be doing. And with experience, you start to develop an instinct, but it's still very helpful when you're seeing a child, you know the age, just to look at what they should be doing. And these are useful things to know, because again, we want to be educating the families well. So often the causes are similar to gross motor delays. As we go on, we're going to talk about why, but it's really important to try to make an assessment of vision. Now, in a small child, that's very, very difficult. You can't get an exact, you can't get them to look at a Snellen chart and tell you how much they're seeing. But what you can do to assess vision is you may want to perhaps shine a light in the eye, see if the child will follow the light, see if the child will basically fixate on various objects. So if you have a colorful toy or something, you may want to play with that and see if the child will follow. And especially this is important for children who have been in a sort of neonatal care unit, where really their vision is being assessed and treated, and where their vision perhaps comes at risk. So for example, a child who may have required a lot of oxygen, or certain medicines may have affected their vision. So it's really important to consider. So that's our kind of second big area. Then we've got our third area, which really is speech and language. Now, the most common issue that happens with speech and language, the most common cause, is actually hearing loss. Hearing loss is really, really common in children and very, very under-recognized. And a lot of the time you'll find children will be sometimes kind of shouted at or berated if they can't follow commands, but often they just can't hear very well. So some of the normal things you would expect to do, really, as a newborn baby, right from the start, will normally get quieter if they're seeing a face and hearing voices that are familiar to them. So that's why we have this whole thing of even people talking and singing to babies in the womb and all of that. There is some science behind that, because it's good for a baby to recognize their mum and dad's voice. 6 weeks, they should be able to respond to their mums. So, for example, Finley, if he's sitting with me in the room and we're playing, and then Bethany comes in the room and starts talking, immediately Finley will look up and will want to see what Bethany's doing. And then right now, he's just started doing what we call cooing. So the first noises babies make is kind of, they might start laughing, or they'll start making kind of ooh, cool sort of noises, just when they're on their own, or they're just starting to get their vocal cords going. So that is just a few early stages that are really important. As they get older, you get what we call monosyllables, so just ba, da, then they move to 2 syllables, usually, at least by a year. And then what's quite a key thing is when they start actually understanding. So around about 13 months, they'll start understanding. So if you say no, usually a child will understand, oh, that means that's not a good thing. And they start to get it. And then as they get older, you can see the vocabulary just gradually increases. But be aware with speech and language, there's such huge variation. And we're going to talk about why in a minute. But some children will have really, really advanced speech, and other children, it will take a very, very long time. The two things, they're hearing, but also their social environment. So a child who is neglected and who is not looked after and who is not spoken to a lot, their speech is going to be very, very delayed, and they will take a long time to learn. Whereas a child where mom and dad are always talking, and mom and dad are always talking to them and explaining the things with them and praying with them and singing to them, they're going to learn to speak very, very quickly and in a very strong way. So this is what we would call really parentally influenced. Again, there's a lovely little poster for this, and I'm thinking I'll probably try and get some of these posters printed out and put up in various places in under fives when I come out. I've got a lot of poster and printing work to do when I come out there to next month, just to sort of not only fix up ETAP, but also some of this development stuff as well. And I think words start to have meanings for children really from about age 1. But they will start using sentences properly really from about 2. Yep, question about the PowerPoint slides at the end of the presentation. Yes, they will be available to everyone. I normally send them over to Garutza. And even if you want for your phones to have these little pictures on your phones, that's actually a very, very helpful thing. So that's our third area. The fourth area really is social and behavioral development. So again, a lot of variability, but there are essentially 2 major stages, and you will know this instinctively if you've worked in under 5 clinic. What you'll realize is that when you're looking after or you're treating a 4-month-old baby, the baby will smile at you, be very friendly, not be crying too much when you come near them. They'll let you listen to them with your stethoscope. They'll let you look inside their ears and throats, no problem. When they reach to 14 months, oh my goodness, different child, very hard to examine them. But that's normal. That's a development stage. And it's something called stranger wariness. Now, stranger wariness is actually, it's part of what children are supposed to do. They become naturally attached to their parents, and they become scared of anyone or anything that looks a bit different. So in Liberia, this can be very hard for me because I look a bit different. So sometimes children, they see me, they just start screaming. Because it's a strange thing, and the stranger wariness comes in. But that's actually good. That means that the child is aware of things that are different. They're aware of what is safe and what is not safe. And so that is a normal development stage that happens at 10 months. And later on, they'll start to wave goodbye as well. And that's quite significant. So there's really 2 things that happen at age 10 months to 12 months that are significant. One of them, the waving goodbye, and secondly, something called casting. Does anyone know what is casting? Does anyone know what that means? So casting is basically if a child has a toy in their hand and they kind of they learn to basically throw it away or put it away somewhere else, or they give it to you. What that shows you is that child understands that objects are going to be in a set place. So before that, children are just looking around at the world, taking it all in. When they start casting and waving goodbye, they understand that things are in a permanent place. We call it object permanence, and then they can move away from those things, and they'll be in a different place to them. So that's quite an important stage when they start to get those 2 things. And then we have what we call self-help skills. These are gradually children get able to feed themselves. Now, obviously, a newborn baby, human babies are pretty much the only animal that are born that are, we are completely helpless at birth. We have no ability to care for ourselves. We're utterly dependent on mum and dad. 8 months, children start to feed using their fingers. Usually by 12 months, they can drink from a cup, but be aware. I'm aware that our census on peds is very stacked with malnourished children. So most of them will not be drinking from a cup and will need a lot of help. And similarly, children feeding themselves from a spoon. So the exception to this really is the malnutrition ward. You cannot just rely on the children to feed themselves. That's what the nurses and nurse aides need to be doing. But then round about 2 years, you'll have a child who will be able, should be, to remove clothes and begin to actually dress and undress themselves. Bowel and bladder training, this is really variable. Sometimes by 2 years, sometimes a lot later. It's actually quite normal for even a 5-year-old to still have enuresis. That's actually normal. So we get concerned if it goes past stage 7. And we get concerned if you have secondary enuresis. So if they start doing it again later on in life, that's a concern. But if it's just a primary enuresis, then we're not really too worried by that. And just again, another of these little pictures. You've got to start with your social smile, and then they start to know who mum is. They start to recognize things are strange. They're waving bye-bye, and then they start babbling. And as that's coming on, then they will start to respond to names and start sharing toys and various other things. And when they get to age 5, they should be able to help you around the house. And obviously you can't go too far with that, but that's basically their stages really that they will go through. And just to say a couple of other things, as they get older, you have something called symbolic play. Now, this really is how children start to make sense of the world around them. So it starts off really as basically just copying things, which is why a lot of outcomes in children and in terms of how they're going to end up as an adult is hugely dependent on their environment. So the first people they copy is their mums and their dads, and then it's going to be anybody else around. And usually by about year 2, they should be playing alongside others, but that may happen earlier, depends where you are. And so really you have essentially 3 sort of stages of basically cognitive function. So if you have a baby, and we learned this, it's very hard, the baby is at the center of their own universe, isn't it? You know, that baby, they believe that they are the only thing, and they believe that they're in the middle of the world, and they believe everything is for them. Now, that is not going to be something that will survive much longer than, you know, preschool age, because if a child behaves like that as an adult, it's not very good. So eventually over time, those thought processes start to change. So you have junior school age, processes are becoming much more orderly. 3 years onwards, they're taking turns. They understand that there are other people who are priorities as well. And then as they get into teenage years, you get sort of abstract thought starts coming in as well, which is essentially being able to not only reason and have constructive debate and arguments, but then also understand what metaphors and similes are. And those are later things. So any questions about those 4 areas before we talk about some of the big issues and delays that can happen?
No.
Okay, that's okay. Well, if you think of things later, we can keep corresponding, and I'm coming there in 4 weeks anyway, so we'll have a chance to talk. So development delays, really, there's 2 kinds. You've got global development delays, and then you've got what we call localized delays. So global delays, that's where you have really all 4 of those areas. So the gross motor, fine motor, speech and language, and social, all of those areas are affected. And then you have localized delays where you start to have just 1 or 2 areas that are affected. So perhaps they may just have delayed speech, or perhaps just their motor functions are delayed. And if you can establish whether it's global or local, that will tell you really what to do and what's going on. And the cause is really important. I mean, you may not get the exact cause, but you can have a very good understanding of why a child has become delayed just by looking at the history and examining really well. So can anyone tell me what would cause delayed walking in a child? Can anyone tell me any answers?
One could be cerebral palsy.
Very good. Cerebral palsy, really common. Can anyone tell me what causes cerebral palsy? Any ideas?
Yeah, so cerebral palsy cool. So you have causes, that's a prenatal causes, or what you call perinatal causes, natal causes, and postnatal causes. So it could be infection. Most commonly infections are common, like maybe prenatal or perinatal the child, maybe the mother is infected. Maybe they could be scraps. Let's say the touches. So and all those can affect the baby in utero, and they can affect that. Yeah, or again, maybe at birth, the mother probably continue or contact of an infectious process, and it will counter affect the baby. And then postnatal, because babies are coming up, their brains are not well developed, still developing, so they can get infection at any time. It could also be, or congenital, but I think maybe what the one I know of, infections are more common, that can cause cerebral palsy.
Yeah,
So,
very good. Yeah.
Another cause could be a difficult delivery, birth aphasia.
Okay, good. Yeah, so we're going to talk on cerebral palsy in a little more detail later, but you're absolutely right. All of those things, there's prenatal, perinatal, and postnatal causes, really, and all of those things are correct. So thank you for those. I'm seeing in the messages DMD, Duchenne muscular dystrophy. That's actually something as well we're going to talk about. Severe acute malnutrition, absolutely. I'm not going to talk too much on severe malnutrition because we've covered that a bit already, but you're absolutely right. So the thing to realize with severe malnutrition, if you have a child who's deprived of, essentially their brain's deprived of glucose, they have issues. I'm hearing someone. No, that's okay. And then also cerebral malaria, very good answer. There's several children who have had really quite serious brain injuries from that. And then HIE, hypoxic ischemic encephalopathy. It's amazing if a baby survives that, and if they do, certainly they're going to have neurological sequelae. So absolutely, very, very good points made there. So remember, anyone who's not walking by 18 months, what you need to do is get in touch with ideally a physical therapist, but in this setting is not always easy, but you can kind of do a lot of your own assessments. And cerebral palsy, you're right, is probably one of our biggest causes. And just to be aware, as we've sort of alluded to a little bit, cerebral palsy is more of a description rather than a cause. It's a bit like heart failure. You know that there's a problem with the heart, but it's really good to think about, well, what happened? Is there an arrhythmia? Is it a valvular thing? Is there an ischemic event? Similarly with cerebral palsy, how did we get here? And we talked about cerebral malaria, infections in neonate, prematurity, all of those things. And really, a couple of key things with cerebral palsy. It is chronic, it's not fixable, and that's really hard because parents are always looking to ways to fix things. It's what we call a static injury, so you're not going to be able, it's not going to get worse, so you shouldn't see a child with cerebral palsy going backwards, but they're going to be very, very slow going forward. So be aware as well, some cases of cerebral palsy, you'll have a localized delay to motor function. Other cases, you're going to have hearing, speech, you're going to have social delays. It's a high risk of epilepsy as well there, as well as blindness. And you may even just have a child with ataxia. So some things to ask, and we covered this a little bit already in your answers, but one of the things that's quite helpful is basically if you have a mother who comes with concern, simply, is there anything different about your baby? In what way is your baby different to other babies? How are they moving? And then you've got to know about, were they born on time? Was it in hospital? Was it at home? How were they born? Was it an operation? Any problems since birth? And then all these things, malaria early in life will cause it, neonatal sepsis, hypoxic ischemic encephalopathy. And then be aware of medications as well. Are we accidentally doing something that might be medicating that, causing more problems than we know about, really? And then speech and sound. So it's quite a comprehensive, if you have a child with cerebral palsy, it's not a 2-minute amoxicillin prescription. It's a long history taking where you'll sit with the child and the mum and maybe the grandma and whoever's been caring for them and really try to understand what happened. So cerebral palsy, like I said, it is, again, my first thing I was saying, it is a description rather than a diagnosis, if that makes sense. So you have all different kind of types of it, and you have what I call spastic cerebral palsy. Now, the key with spastic cerebral palsy is that you have this increased resistance to stretch. So it's an upper motor neuron lesion, and that means that you have increased tone in the muscles. So if you have a lower lesion like motor neuron disease or something like that, you would have reduced tone. In a upper motor neuron lesion, you've got increased tone. So that has a lot of implications, and you may see children you've probably all seen children in this condition. The wrist and elbow is flexed, the shoulders held in this sort of funny adducted position. You try to lift it out and it just won't go. Deformed feet, and then you have what we call a clasp knife phenomenon, really. So that's where you try to stretch the tension. Stretch the tendons. Perhaps you maybe try and stretch the Achilles tendon, and it just snaps back straight away. It doesn't really do anything. So those are just important features to see. And within that, you've got subtypes. So there are certain types that are one way and certain types that are the other. So really, the most common one is actually what I call a hemiplegic spastic cerebral palsy. And that's where you have, you can see everything's on one side. So if you see the first picture there, you may have a child, one side is normal. So you see that left arm, nice and normal. The right arm is held in a flexed position. They're unable to really use it. And then they're walking perhaps on one foot. And then later on, you'll have, that will be fixed. So the child may try, you have to use walking aids, things like that, but they're basically stuck. Then you've got a diplegic situation. That's usually, that'll involve both legs. And these children, it's very hard because they can't walk and they need a lot of support. But the upper body is usually entirely normal. And then the most severely affected quadriplegic cerebral palsy. I mean, these children will not be able to walk or move or really do very much at all. They may even have an impact on their upper body or their face. And usually children in this condition will often have quite a severe learning disability, delayed speech as well. So those are basically your broad subtypes, and it's quite helpful when you're seeing a child to try to classify them. What do they have? Is it one which is this the child who has a diplegia, in which case the support's going to be focusing on walking, and you can actually probably encourage the mum that actually that child will probably have good brain function. That probably, in terms of their cognitive ability, they'll be able to do things with their arms. Or are we looking at a hemiplegic situation where perhaps there's more of an impairment? And so, yeah, this is another illness which is not really very easy, chorioathetosis. This involves all the limbs, really, and again, this is as a result of a brain injury. So very, very similar to cerebral palsy, really, but the main difference with chorioathetosis is that these children have difficulty swallowing as well. Now that's important because that means they're prone to malnutrition, and they are very likely, they can get into a bad cycle. They get malnourished because they're not swallowing very well, and they're getting pneumonia because they've got these bulbar problems, and then they get sick, and then they're malnourished, so then their development goes backwards, and all these things all kind of go into a bit of a problem together, really. So yeah, that's just something to bear in mind, and just to be aware of. See that rarely. Now, the main way to find out what's going on essentially is the history, as I was talking about. So you want to examine neurologically, but the history taking, how did this happen? Was there, one of the helpful questions is, has there ever been a time when your child was able to move like normal children? And if they say yes, but this thing happened like malaria or some other something, then you know what's going wrong. Or if they say, oh yes, when until age 3, he was fine. And then he started to slowly go down. Then you know you're dealing with a different condition, because that's not cerebral palsy, that's something else. So the mainstay of treatment is not going to be stuff we can medicate. So I find these children very hard to manage, because so often they can give them something, like you can give them an injection or something and everything will be fine, but you can't. So the main thing is the education side of it. You don't want the parents spending all their money and getting sick, just running around trying to get help from people who aren't going to be able to help them. So it's really important just to be aware of all of that. So other things as well, wheelchairs, walking aids, they're all really helpful things as well. Just liaising with, if you know anybody in the community who has any occupational therapy training or physical therapy, that kind of stuff is really, really helpful as well. And I want us to someday, I really want us to set up a sort of a proper kind of clinic for children with cerebral palsy with walking aids. If you ever find yourself in Bond County, there's one place, it's called His Safe Haven. It's in the outskirts of Bangor. They have a little home for these disabled children. And they have about 30 of them living there, and they have all wheelchairs and all these physical therapist people who are trying to help them. So that's, if you find yourself in Bond County, if you look it up, His Safe Haven, it's really interesting, and you can go and meet them there. Good. So Dr. Goner, you'd mentioned muscular dystrophy, so wanted to touch on that. Muscular dystrophy is rare, but it's really important to know about. So I'm just going to ask you a couple of things. If I say something's X-linked recessive, what does that mean? What does that mean to you if I say that?
The mother is a carrier.
Sorry, the mother?
The mother is the carrier.
Okay, yeah, very good. Excellent. There we are. So the mother is the carrier. What does that mean for the child? So maybe it's not a I'm seeing something.
It means that she's going to transfer the genes to her boy. It's mostly for in boy children.
Very good point. Mostly in boy children, because with it being recessive, you need 2 genes to have the child affected. But a boy, they'll have a Y chromosome. So if you have the condition in the X chromosome, then there's no opposing thing to stop it. So you have, usually you'll see it in boys. So that's a very important point. Yeah, good point as well. We have a couple of cerebral palsy children here. How can we innovate a physical therapy or get help from abroad? There are good systems out there. So yeah, I think this is a really good point. There is a group there's 2 groups that I know about that are helping a little bit. There's a group in Freetown in Sierra Leone where they have, it's called World Hope. They have people who have come and done physical therapy and things with children. So we could look at setting something up with World Hope. And I know they were also trying to work with a team in Bangor as well to see if we can put something together. So you're right. This is where we need to try to help people, is have some physical therapy. So things you see on exam, this waddling gait. I'm going to show you some pictures in a minute. But the main couple of things to realize is this is actually progressive. So rather than development just
what we need to do,
it actually goes backwards.
Just warm.
And the main area that's affected is the limbs. So the face will be normal. The eye movements are normal.
I warmed water. I put water here.
I'll show you just a little
just
picture.
Put there. Come into wipe here.
This is called Gower's sign. This is how a child will stand.
Warm this to then bread is there.
They have real weaknesses in their legs, especially
so what to do? Just let me change it.
Yeah, if we could just mute our mics a second there. And especially their thigh muscles can be very, very weak. So they're like climbing up their legs. So if you ever see that in a child, you should immediately be thinking, could this be a Duchenne? Now, the blood test for it is strange. It's called creatinine kinase, and it's to do with the muscle tissue being broken down. So raised creatinine kinase is how you find out for sure. That's one you would need to probably send to Jamali Lab. I don't think we have that one here. But clinically, you can discover and raise suspicion of it as well. So other things to say, what we call the waddling gait. So basically, the issue is the limb girdles. So you end up with other muscles becoming very hypertrophy.
Right. So I didn't need to order anything.
And be aware, prognosis is poor.
Just
So
grab anything. Yeah.
children with Duchenne will often not even survive years. A lot of the time, their respiratory muscles just essentially fail and they just don't make it. So it's a horrible condition. And again, there is not very much you can do. You're just trying to support them and treat them through it. There's a more mild form called Becker muscular dystrophy that more affects teenagers. So we won't go into that too much, but just to know you have the two, and Duchenne is the one which is really, really severe. Any questions on Duchenne or cerebral palsy? Hey, someone is trying to ask a question, but the internet is not strong. Yeah, sorry, carry on.
Yeah, so what I want to, so thank you for the presentation. What I want to know is that, first of all, I want to say that cerebral palsy is an insult to the developing motor brain of the infant.
Mm-hmm. Yeah, and
that will lead to all of those symptoms. But I want to know, you mentioned chorioathetosis.
Mm-hmm.
So also etiology-wise, what's the difference between chorioathetosis and then CP? What leads to chorioathetosis? That's probably different from cerebral palsy.
Sure. Yeah, you're absolutely right in that. Yeah, sorry. So yeah, you're absolutely right in that, you know, cerebral palsy is an insult to the brain. Now, chorioathetosis has a much kind of wider range of causes, really, and there's actually a lot of infective causes which can do it as well. So I probably should have put a bit more on there. I didn't talk too much about it because it's quite rare, but I wanted just to, yeah, now that we're in it, we can talk on it. So various other conditions will do it. Meningitis will sometimes cause some of these movements to happen, and that can be there for a while. Encephalitis as well. Other conditions, advanced stage HIV or AIDS, you know, children with HIV is a disaster. Even on treatment, sometimes they can have treatment failures and go backwards and get brain damage. That's a cause as well. And then also there is a whole range of kind of metabolic or endocrine conditions that will do it as well. So basically, it is essentially a sort of chorioathetosis essentially is an overstimulation of the basal ganglia within your brain. So that's why you end up with these, let me just find it again, the little piece out of it, and these sort of overdone movements, really. So that's why you get the increased tone, is the basal ganglia are overstimulated, and you have swallowing difficulty as well. But the point with it is it can be to do with perinatal events, but it's more likely to do with an infective cause later on. So, yeah.
All right, thank you. And then another thing I want to know, so the child's brain development, I mean, at what age does it stop developing?
Okay, very good. What age does it stop developing? Do you mean in a normal child or in someone with a condition?
Yes, a normal child,
Yeah, I mean, I guess the answer is really, I mean, we sort of reach our peak kind of cognitive function around about 18 to 20 years old. But in terms of development, we're, yeah, I mean, really by the age of about 21, we've developed about as much as we will with our, in terms of our brain function. But at the same time, there are still changes going on. So, for example, in a teenager, sort of a 17, 18-year-old, they will have essentially less of a sort of prefrontal cortex involvement, which is why younger teenagers will often make rash decisions. So they may do things that are unwise, you know, they may take drugs or have intercourse or whatever. whereas as we get older, our brain functions change and we start to develop more inhibitory pathways. So it's not an easy answer because our brains are always developing in some way or other, but really gross and fine motor, probably that should be pretty much in there really by the age of even 8 or 9. Yeah. Okay, good points. Good question. So just to come back, so delayed speech, I don't want to talk too much on this, but delayed speech is really important to recognize because it's actually quite treatable. A lot of the time it's to do with hearing issues. So children who can't hear will not learn words and can't speak. So it's really important to look in a child's ear if the mum says they're not speaking. And if you're seeing signs of otitis media, for example, I mean, your ENT lectures, you'll probably hear about that. Like if the sort of, you know, for example, you see the tympanic membrane's got a dullness to it, or the child says the child's had many like otitis infections there just again and again, then that would suggest possibly otitis media, and that reduces hearing. But then really commonly, and this is very, very much on the nutrition program, a lot of these children are not being stimulated in the right way. So their speech is delayed because they're just not hearing enough sounds. And then other things as well, family history, there are various kind of congenital things where everybody's got it. Everyone's just naturally speaks quite late. And then be aware of certain global delays. So there are some which will not affect motor function. I'm thinking specifically autistic spectrum disorder. So, you know, I have a relative who has autistic spectrum disorder. It was very interesting. His speech wasn't delayed, but it was very different. So he learned certain sentences to say them really well, and then other things he just wasn't even interested in learning. And we'll talk about that in a second on the social side of it, but just be aware, usually there's a hearing issue or there's an environmental issue if you've got delayed speech. So it is fixable. And again, kind of a global delay. This again is all the areas. So we talked about cerebral palsy, and there are so many things. Now, malnutrition is really our number one. And I would say that the thing with malnutrition is it's usually a situation where the child may have been developing quite well and then they go backwards because they just aren't getting the nutrients that they need. But other things as well. So teratogenic events, so mothers who are drinking or using other substances, it's going to be real consequences later on. Congenital infections, rubella, CMV, toxoplasmosis are your commoner ones as a whole. We call the kind of torch list of infections. We'll talk about that another time, but there's a lot of things there. And then things that go on with mum. So if mum has an untreated thyroid condition, or if the mother has some kind of, you know, if she's anemic because perhaps she's had malaria and she wasn't getting any prenatal care, then very, very often there's a kind of a global developmental delay there, which will come in. And then we know about all these things as well. So our perinatal insults, we talked about these. Important to be aware, children who have recurrent hypos, they are at risk of longer term brain damage, which is why one of the reasons why we are, you know, I try to push a lot of this thing of making sure children do get feed and fluids regularly, because if we're just going from one hypo to the next, just giving D10, 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 you know, just treating hypos, in the long run, that child could well have brain damage as well and develop some of these problems. And then as well, be aware, so extreme prematurity. So when Finley was born, he was constantly having ultrasound scans of his brain because we were concerned. I mean, he has no problems now, but there was always a worry. We want to make sure that he hasn't had any intraventricular hemorrhages, which is essentially a big bleed into his brain. So if that happens, usually that will happen in children who are maybe 32 weeks or less. That can be catastrophic. Often those children will not be able to, you know, they'll have severe cerebral palsy, usually a hemiplegic variety, because it's one hemisphere will be affected. And then even straightforward neonatal sepsis will cause that as well. We talked a little about our, you know, brain injuries, and, you know, suffocation children constantly running with low oxygen levels, that's really bad for brain development. CNS, infections as well, encephalitis, that is actually quite common for children who have had encephalitis to have these really nasty sequelae later on in life as well. So treat those things early. So we did some on genetic disorders. I know there was a request to do a bit more on those later, but usually it's quite easy to tell if you're managing a child with cerebral palsy, or if you're managing a child who has perhaps something like a Down syndrome or some other kind of genetic disorder. It's not normally too hard to tell the difference, but just keep that in mind, especially if you sometimes you'll look at a child and you think, oh, they look a little bit different, or there's something a bit strange going on. So really worth considering in the back of your mind genetic disorders as well. They are very common. I mean, we always end up talking about trisomy 21, but there, as rightly pointed out, there are many others, as Edwards and Patai and all these other ones that are rare, but it's good to consider them. So I think I'll kind of stop there for now. If I do that. Any questions?
Yes.
Yeah.
No question per se, but what I've noticed about one family, there's a lady who got married, but when she got married, she had a niece and nephew living with her. When you talk about child development and speech development, so she had her nephew living with her. So before she started having children, those nephews and nieces started calling her auntie.
Oh.
So when she started having her own children, started calling her aunt.
Interesting.
So it just ran to my mind when you talk about speech development and child development. Mm-hmm. So she tried as much as possible to make her children call her mama, but it was not possible. So the first set of children started calling her aunt, and the second set of children started calling her aunt, and that's how it is now. All her children and other people call her auntie. Yeah, so it's important when the children are coming up, especially in terms of speech, you do your best to make sure they do the right thing.
Yeah, very good point. So children will copy, the first few months they'll just be copying everything. So that's a really good point to be aware. So if all they hear is auntie, that's all they will say. So yeah, I'm seeing Roosevelt Matthews, I'm seeing your hand is raised. Do you want to unmute yourself? Yeah, Roosevelt Matthews, you're still there? Your hand is raised. Could be an internet thing. That's okay. Don't worry. Any other questions at all?
Yeah.
Yeah.
So the pharmaco.
Sorry, I'm losing you there. Do you want to try putting it in the chat? I'm losing your voice. Sorry. Let me just see if something comes in the chat there. Okay, pharmacological therapy for spastic cerebral palsy. Yeah, challenging. So you can treat associated problems. So you can sometimes use baclofen to treat someone who's got really difficult spasms, that's worth a try. Sometimes you can use Botox injections just to relieve some of the spasticity in the muscles as well. And you can often get seizure activity. So you can use usually carbamazepine or lamotrigine would be your first line anti-epileptic drugs there to try to treat some of those some of those associated seizures. But very, very hard to treat. I mean, you don't want to really put them on diazepam and things like that because they're highly addictive and they're just very, very sedating. So I would steer away from that. But there's some evidence for baclofen, but it's not too strong. So that's about it, really. It is mostly about encouragement and support for the parents.
Okay, thank you.
Okay. Thanks, guys.
Thank you, Dr. Mikey.
Yeah, thank you. So I'll see you all in about 4 or 5 weeks. We're on the way. So sorry for this long delay, but baby is doing well now, so we're on our way. So
Okay, say hi to Finley and Mom.
I will. Thank you.
Are you bringing them?